Good evening. Today's talk is going to be on the pre-IVF treatment for fibroids. Is there a role for the medical method? When should the clinician treat a fibroid in women with infertility? The indications for treatment should be established with the care because of the association between fertility and fibroids may not be evident in certain situations. When you look at it, you can really see that this particular group of from 0 to 5 is a main cause of the fertility myomas and fertility. If you look at the cause, we know that submucous fibroid has got a thicker capsule and uterine cavity distortion, and the others like intramural have an impaired blood supply, the gene altered gene expression, and the molecular changes with cytokines and increased uterine contractility, as Dr. Gopinath said. We know that the submucous fibroids do have a cavity distortion and the pregnancy rates come down. And the endometrial and the myometrial blood supply, which is very close to the type 3, probably it interferes with the endometrial blood flow. And the studies have proved that definitely the increase in myoma volume was greater in highly vascular myoma, strongly supporting that the blood supply modifications may affect blastocyst implantation. Let's see whether the medical management do improve this blood supply. Again, the uterine contractility, the intramural myomas induce the abnormal uterine peristalsis, resulting in lower implantation and affecting the surrounding myometrium and lead to increased uterine contractility. And hormonal and molecular changes also because they modify the gene expressions and significantly impair the gene expression in endometrium. Again, the alteration, the vasoconstriction of spiral arterioles, both the submucous and the intramural myomas interfere with the uterine contraction and thereby at the level of the functional zone, and we know that it impairs the implantation. And especially this intramural fibroids, which is again a controversial one because it produces the disruption of the junctional zone, changes in the estrogen and the progesterone receptors, increase in the aromatase, and possible changes in the progesterone receptor, which occurs in the intramural. Probably let's see how the medical management would change these things which could interfere with the fertility. And again, we know that the Hoxha turn is lower in the submucous as well as the intramural fibroids. So the thing is, the larger fibroids create more of TGF-B, and the TGF-B operates and has a diffuse molecule to alter this BMP expression. So the increase in amount of TGF-B3 probably reaching the cavity, therefore probably interferes with the infertility treatment as well. We know that the thicker capsule is normally, whether it is an increased pseudocapsule thickness, also boosts the neuroendocrine fiber numbers, but their presence may affect the muscle contractility and uterine peristalsis. Again, the uterine natural cell has also been affected by these fibroids. So the size of the myoma and the proximity, the type 3 myoma measuring 2 centimeters or more situated very close to the uterine lining will have a detrimental effect. So when you have a very small fibroid, which may not be accessible by a myomectomy, probably, let's see whether the medical management would be beneficial. Again, the type 3 intramural fibroids, we know that it do not significantly increase the clinical miscarriage rate, but it does have an impact when there is about more than 2 centimeters. Again, by the donors, we found that a lot of studies prospective, nearly 5,000 people, and found that the non-cavity distorting intramural fibroid also do have an adverse effect on the live births. And as Dr. Gopinath said, the junctional zone, it makes a lot of difference in the fertility treatment. And the fibroid that affects the junctional zone. So for this reason, people thought that that is type 4 should be further classified as 4A and 4B. And then 4A probably disrupts the junctional zone and the type 4B does not. So probably there appears to be a sufficient evidence that the intramural fibroid with particular group do affect the fertility. Again, the clinical pregnancy rates, they said that there's not much of difference, but if you have a higher clinical pregnancy rates when the fibroids about more than 5 millimeters away from the endometrial lining, that is very, very crucial. So if you have very small fibroids, how do we deal with the surgery? So such cases, probably the medical management would be beneficial. Sunkratal again said that yes, the live birth rate comes down. As Dr. Gopinath said, there's a cumulative, the live birth rates comes down. So even if it's a smaller fibroids, if you look at in a single cycle, it may not affect, but if you look at the cumulative, it thus brings down the chemist. So such small fibroids need to be addressed through the medical management. And again, Cochrane, as we all know that not much of evidence by the surgery. So this is something was brought by the donors, a migration effect, whether the medical management depending on the size and the proximity, whether we could push the size of the fibroid into the myometrium. Let's see whether it is possible. It is obvious that not all fibroids produce infertility, and surgical treatment may be time-consuming, and probably in addition rates are very high. Challenge is which fibroids needs to be removed, how many fibroids, the size, and very close to the proximity as well. The indications of the medical management pre-IVF, probably previous myomectomies, many surgeries in order to avoid another surgery, smaller fibroids less than 2 centimeters, very close to the junctional zone, intramural fibroids which abut the endometrium without discharging cavity. When you have all these conditions like recurrent implantation failure or recurrent pregnancy and egg donation program where you have a smaller fibroids or ovarian reserve, not willing for surgery, patients could offer this medical management pre-IVF. And again, we know that 12% do have an intrauterine additions, and oocyte recipients, fibroid not discharging the cavity could constitute a risk factor, so probably that needs to be addressed. So again, this is a fertile battle by the Dolman et al., who discussed that the pros and cons of removal of the symptomatic fibroids. So probably pre-IVF medical management comes into play. We know that the medical adjuvant treatment before surgery for fibroids gives a very good results. Why not pre-IVF? So these are the various drugs being produced, but whereas very few drugs have been resulting good results for the fibroids pre-IVF. That is, you have the selective progesterone receptor modulators, the mifepristone, the GnRH agonist, antagonist. When you talk about the ulipristal, the selective receptor modulator exerts an agonistic and antagonistic effect, modulates the progesterone effect on different tissues, effective in reducing the uterine fibroids volume, and this effects last over time. And there's a lot of studies have been found. Very interestingly, one people have done a very small studies with 26 patients with submucous fibroids. And what they did was about 3 treatment cycles of ulipristal acid, and they found that 57% of patients did have a biochemical pregnancy and a volume reduction in 41%. So probably restoration of the uterine cavity may be possible with a single dose of 5 milligrams for 3 months. Again, there's another study, 23 women with symptomatic fibroids, whereas type 1 to type 2, according to the FIBO classification, where they found that and a lot of disturbance, please. So this is a treatment with ulipristal acid. After treatment, they found that the distortion of the cavity reduced in high percentage, about 85%, very surprisingly, with submucous fibroid, and 86% did have a pregnancy test. Another very small group of 13 with treatment with intramural fibroid after a washout period with an ART, and they found that they did have a 61% of positive results. So again, we know that ulipristal represented a non-invasive medical treatment. Fibroids were meant for the IVF, not only women affected by the submucous, but also by the intramural fibroid, which is not distorting the cavity. So single 3 months course of treatment. This is preparing a more favorable environment before ART. Again, we know that it alters the expression of the growth factors, modulates the expression of metalloproteinase by modulating the ratio of progesterone receptor isoforms. We know that ART, ulipristal acetate, could be the best option because it could reduce the fibroid size. Endometrial biopsy did not reveal any histological changes. It was benign, reversible, and without negative consequences. So it seems to have a triple effect. Prompt symptom relief, reduces the myomas, improves the morphology of uterus. So what do we want more than this? Again, before we go ahead, if you have a fibroids of more than 4 centimeters, that do not support pre-IVF myomectomy in women with small to moderate size. So probably a valuable information in counseling the women with fibroids because they require probably an increased number of cycles. Again, that if you have a woman with advanced age and prominent intramural fibroid, counsel the patient that you give them 1 or 3 cycles of IVF, aim to cryopreserve 5 to 10 embryos, and then followed by 12 weeks of the ulipristal, and then subsequent FET with their own previously cryopreserved embryos is possible. In the antagon, we know that it improves the bleeding patterns and reduction in the fibroid size as early as 3 weeks because of its rapid onset of action and avoidance of the gonadotropin flare effect. Patients experience faster symptom relief. So antagon could be the choice pre-IVF. We know that the fibroid volume considerably comes down, but without an add-back therapy. With add-back therapy, there was a delay in the reduction in the fibroid volume. So people used various doses of 200 milligrams or 40 milligrams of relugolix, and they found that the reduction in fibroid volume was better. So significant reduction of the myoma and the uterine volume after 12 weeks of 200 milligram was is probably with the antagon periodically. At baseline, if you see a fibroid volume of 396 has come down to about 196. Again, the next drug could be an aromatase inhibitor. It blocks the extragonadal conversion of the androgens into estrogen, and this property makes very attractive candidates for the medical treatment of uterine fibroids. And they say that the aromatase as effective as analogs in shrinkage of the fibroid volume despite the stable levels of circulating estrogens as well. So this was a study when compared the letrozole with the agonist, and they found that the letrozole of 2.5 reduced the fibroid cells of 45% when compared to triptyline of only 33%. And this was another study compared the letrozole versus gonadotropin, and they found that the group B received 2.5 for 12 weeks, group B received triptyline, whereas the group A did reduce the fibroid size 45% without the change in the hormones, whereas the group B did reduce only 33% with the reduction in the hormonal size. And these are the drugs which have been used, but again, Cochrane did not conclude to use because the evidence was still insufficient. So conclusion with aromatase, probably the uterine myoma was successfully reduced by the aromatase inhibitors. Probably could be who wants medical management for a transient period, who wish to avoid surgical, specifically women with an unexplained infertility having this sort of myomas. Probably people thought aromatase could be beneficial. The study, there was another study compared the letrozole versus the combination of cabergoline, and they found that 12 weeks of treatment with letrozole with or without cabergoline did improve the size and the volume of the uterus, led to the symptom improvement, and could be used as a short-term treatment prior to the fertility program, again published in 2017. And the cabergoline was well tolerated. This was a study compared the cabergoline along with the analog, and they found that the therapeutic efficacy and fewer side effects. The dopamine agonist may hold a promise as a novel treatment modality for the fibroids. The other study compared the Dynagest 2 milligrams with the leuprolide acetate, and consideration of the GnRH disadvantage because of the hypoestrogenic things. And Dynagest probably led to a short or the long-term management who wish to avoid surgical intervention prior to IVF. This is again a latest publication. So coming to the agonist, which most of us use, pre-operative agonist reduces the uterine and fibroid volume. Therapy probably reduces the fibroid for about 35%. So probably before the induction and producing an induction of amenorrhea. It significantly reduces the fibroid volume, the impact on the cavity encroaching the fibroid, and subsequently improve the implantation. Another drug is a mifepristone, where they gave 50 milligram when given bi-weekly doses. It was very safe, and reduce the fibroid to 37%, whereas intramural to 36% and submucous to 33%. The only thing is people were worried is about the endometrial hyperplasia. The systematic review did not support the use of mifepristone. Again, Cochrane did not support the reduce of fibroid volume. Again, a small little word about this adenomyosis. The ultra-long protocol probably had a better benefit before the IVF treatment, and it did improve the clinical pregnancy rates, especially in a diffuse adenomyosis. Whereas another study said that modified down regulation could improve the clinical pregnancy rates by reducing what is modified. That is, they gave the analogs for about 6 weeks to a standard, but down regulation for 1 week prior, and they found this modified had a better chance when compared with the standard ones. But the other controversy was one group said the agonist did not improve the live birth rate as usual, because you know that lots of controversies raising, but most of the patients did benefit with the ultra-long protocol. To conclude the pre-IVF medical management, I would say that pre-IVF diagnosis of the location of the size of the fibroid is very, very crucial. Whether you have a 3D ultrasound or an MRI, patient wish, if they want to avoid the surgery, probably you can give them a medical management. Select a subgroup of population who would benefit. That is, if you have a smaller fibroids very close to the junctional zone, previous patients who had a recurrent implantation failure or previous myomectomy, the choice is probably a very selective group of patients who would benefit from medical management. Counseling prior to the medical management is very crucial. These are the drugs which have got a short-term benefit, as I mentioned earlier, the SPRM, LHRH, antagon, aromatase prior to IVF, reduction in the size, volume, and then improvement in the endometrial receptivity, and probably an ultra-long GnRH agonist or adenomyosis could be offered pre-IVF for the beneficial of the patient. And again, I would say that yes, pre-IVF treatment of fibroids is this possible for a selective subgroup of patients. Thank you for the opportunity.
Yeah, Gobinath, Dr. Gobinath, please introduce Korean. Please introduce Dr. Korean.
Hello.
Yes, please introduce Dr. Korean. Thank you.
Hello. This is to introduce another stalwart and a close friend of mine for more than 4 decades, Dr. Kurian Joseph. And he is the generation after generation. His grandfather was a president of the Obstetric and Gynec Society of Southern India, and his father was a president, and then he was a past president, and he has got his name well established in the Asia Oceania as a president. He is a stalwart in endoscopy, not only doing, teaching and training several people all over India and in the overseas countries. So we have Dr. Kurian with us to talk on the laparoscopic management of the fibroids. Can we have the recorded talk, Antonio?
Yes, please. Yes, we will play his course video.
Yeah.